Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's program. Today's program is entitled Orthopedic Essentials for the Qualified Medical Evaluator. And the purpose of today's program is to share with you some key concepts and ideas from chapters 15, 16, and 17 of the AMA guides. And if you've reviewed or read your AMA guides anytime recently, you will recall that the AMA guides advise us that as evaluators, in the performance of permanent impairment evaluations, our job is to focus on the true objective physical examination findings. Well, this can sometimes prove to be difficult for qualified medical evaluators because examinees have a tendency to confuse and confound evaluators with loads and loads and loads of subjectivity that they bring to the face-to-face evaluation, and specifically they bring to the physical examination. So in today's program, we're going to focus on the nature of true objective findings as relates to the physical examination of the spine, the upper extremities, and also the lower extremities. Now, it's interesting, a recent 2017 study published by the Workers' Compensation Institute Review Board here in California found that the California workers' compensation system ranks dead last, 50th place out of 50 states in the number of examinees in the workers' compensation system who go on to receive a permanent impairment rating. So it seems that in California, qualified medical evaluators are finding permanent impairment in examinees, whereas the same examinee in other states are being found to have no permanent impairment. So it seems that in California, the rate at which examinees are found to have permanent impairment exceeds the rate of all 49 other states in the nation. And you might ask yourself, well, why is that? And the reason can only be because qualified medical evaluators are not clear on the nature of true objective findings. And qualified medical evaluators are becoming confused and confounded by examinee subjectivity. Now, examinees in the workers' compensation system are going to come to us and are going to report pain symptoms. So the first section of this program is going to deal with several concepts related to pain and pain as it relates to the California workers' compensation system. And I'm going to show you exactly how to determine how much pain your examinee is truly having on an objective basis, despite what they may tell you subjectively. And also, you're going to learn how to assess how their pain impacts their activities of daily living, if at all. And I'm sure that at the conclusion of this program, you're going to start seeing a trend where you realize more and more of your examinees have no true limitations to activities of daily living. What they will simply report to you is that they have pain with activities of daily living, but pain is not the same as a limitation with activities of daily living. So in section 1 of this program, we're going to explore many concepts related to pain as that pain relates to examinees in the California workers' compensation system. Then in section 2, we're going to talk about the general nature of true objective physical examination findings in general as relates to the spine, as relates to the upper extremities, and as relates to the lower extremities. And then finally, in part 3 of this program, we're going to dissect the physical examination of each of those regions, the spine, the upper extremities, and then the lower extremities. And we're going to talk specifically about how true positive physical examination findings will manifest in the physical examination, and how the absence of true objective physical examination findings gives you an indication as to the true condition of your examinee and their true limitations, if any, upon their activities of daily living. So I have a fascinating program for you. I'm sure this is going to be immediately helpful to you with your very next examinee. And so, with no further ado, let's get into today's discussion with our first section related to pain. Okay, so let's begin. And let's begin with a discussion of the topic of pain. Now, no QME continuing education program that deals with the physical examination and the face-to-face evaluation would be complete without first a discussion of pain, because examinees are going to be telling us about the pain symptoms that they're having. They're going to tell us that they have pain at rest. They're going to tell us that they have pain with activities of daily living, and they're going to tell us that they have pain on physical examination maneuvers. And our job as qualified medical evaluators is to sift through this examinee's subjectivity to arrive at a determination of the examinee's true condition and arrive at an opinion or conclusion for the examinee's true permanent impairment rating, if they even have a permanent impairment rating at all. And because examinees themselves are going to be so focused on convincing you that their pain is terrible, it's essential that we come to a common understanding about several of the pain concepts that relate to our physical examination with examinees. So let's talk about pain. So first of all, what is pain? How can we define pain? Well, there's some key definitions of pain that give us great insight into our examinees and how true pain affects examinees' activity, both activities of daily living and also activity in the physical examination. So Merriam-Webster defines pain as a localized physical suffering associated with a bodily disorder, such as a disease or an injury. They continue and they say that pain is a basic bodily sensation induced by a noxious stimulus. And in the face-to-face evaluation, the noxious stimulus is going to be your physical examination maneuver, which has as its purpose to stretch, compress, irritate, or otherwise activate pain receptive endings. Okay, so you can think of your physical examination maneuvers as a noxious stimulus. Well, the noxious stimulus is received by naked nerve endings. We refer to those as nociceptors, and is characterized by physical discomfort, a physical sensation of discomfort. And examinees will report various sensations such as prickling, throbbing, aching, stabbing, pins and needles, sharp, dull, and all these adjectives that they will use to describe their physical discomfort. And finally, Merriam-Webster tells us a key aspect of pain that I want you to pay particular attention to, and that is that pain typically leads to evasive action. People in pain don't want to go to those places wherein they experienced pain before. It's kind of like that old joke. What do you do if you break your arm in two places? Well, you make sure that you never go back to those two places again. And that would be a form of evasive action. Well, evasive action is critical to the definition of pain because in your physical examination maneuvers, you want to be looking for the true objective physical examination finding, which involves evasive action. So when you perform a physical examination maneuver that compresses, stretches, or otherwise irritates these localized naked nerve endings, your examinee will demonstrate an evasive action. And just to give you an illustration of evasive action, I want you to think back to your orthopedic training wherein you learned the shoulder apprehension maneuver. There's also an apprehension maneuver in the knee for the assessment of stability of the patella. Well, if you think about both of these maneuvers and the diagrams that are depicted in the orthopedic textbooks in describing these maneuvers. You'll recall with the shoulder apprehension maneuver, as the examinee starts to sense an impending dislocation of their shoulder as the shoulder goes through this range of motion involved with the shoulder apprehension maneuver, as the examinee senses an impending dislocation of the shoulder, the examinee will create an evasive action to reduce the possibility of the impending dislocation. So this evasive action is reflexive. It's not cognitive, it's reflexive. It's a takeoff on the principle of the evasive action that's associated with touching your finger to a hot stove. And you'll recall those lessons back in your neurology training. When you touch your finger to a hot stove, instantaneously there's an evasive action. There's a co-contraction of multiple muscles in the upper extremity designed to remove your finger from that noxious stimulus so as to avoid further damage. So evasive action is critical to the definition of pain. And I want you to pay particular attention to your examinee to see when and how and where they demonstrate various forms of evasive action. Okay? Okay, so pain is therefore an unpleasant sensory and, critically important to understand, it's also an emotional experience which can be associated with actual tissue damage or potential tissue damage. Now, examinees in the workers' compensation system may present to us with persisting actual damage that actually continues to persist all the way through the date of the qualified medical evaluation with you. They will also experience pain due to potential tissue damage as you go through your physical examination maneuvers. And an examinee who senses that your physical examination maneuver could cause potential or further tissue damage to already injured parts of their body, they will demonstrate to you some sort of evasive action, and they may also demonstrate to you some sort of an emotional reaction as well. So when we think about the loops and the pathways involved with pain, and as we begin to dissect the various locations along the pathway where abnormalities in the pain processing can develop, we need to ask ourselves, where is the sensory perception of pain picked up? Well, the sensory perception of pain is picked up, as we said, in the periphery, in naked nerve nociceptive endings, out at the site of actual tissue damage or out at the sites in the periphery where there is the possibility for potential tissue damage. Well, as we trace the processing of that pain signal from the periphery to the central and all the way up to the brain, where is the emotional perception of pain? Is that something that's experienced out in the periphery? No, the emotional perception of pain is experienced in the mind of the examinee, and we know that the emotions, especially the emotions of fear, dread, impending doom, those are picked up and processed in the emotional centers of the brain, such as the limbic system, such as the amygdala, such as the thalamus, such as the pre-tegmental regions. So we have these pathways from the periphery, where localized nerve endings are stimulated, all the way up into the central, into the spinal cord, and then ascending up into various brain areas, including the emotional areas in the brain that are associated with the processing of pain. Now, examinees are going to describe to us two basic types of pain, and each of these types of pain have their own particular and unique presentation. So we have acute and chronic pain. Now, it's important to know how each of these types of pain are going to present to you clinically in the physical examination of the examinee. So there has to be, it's important that the examinee's pain characteristics are consistent with the chronology of the history of the examinee's case. Many times we'll find inconsistencies where examinees describe for us acute pain symptoms in a chronic setting, or they will describe chronic pain symptoms in an acute setting, and there's this mismatch between the symptoms that the examinee reports and the history of the case. So acute pain is defined as new pain. An acute pain is a new pain. Now, typically when you develop a new pain, many times that pain is often severe, it's often continuous, and it's perhaps disabling, and is of sufficient quality or duration that the patient or the examinee will seek medical help. Now, this type of pain is sometimes associated with anxiety. Now, if you yourself have experienced any type of acute pain recently, typically the acute pain is of the variety that we define as moderate or severe type of pain. And we're going to talk more about the different types of pain, from minimal pain, slight pain, moderate pain, and severe pain in a couple minutes. But it's important to realize that many times acute pain is of the moderate or severe quality of pain, meaning that when you have acute pain, the pain is disabling and the pain interferes with activity. Think of a person who has a limp. A limp is an evasive action away from pain. It's quite interesting how some of these concepts start to come together as we assess examinee pain behavior, and as we observe our examinee going through activities of daily living. A limp is nothing more than an evasive action, and we can tell by the severity of the limp how bad is the pain. A person with a low level of pain, perhaps a minimal pain, will have no limp at all. There will be no evidence of an evasive action. But as the limp becomes more pronounced, more disabling, that tells us on a positive objective finding basis how bad that pain is. When pain interferes with activity, we define that as moderate and severe types of pain. It interferes through the presentation of an evasive action. So you need to always be attuned to your examinee's presentation of the various forms of evasive action. Now, acute pain is sometimes associated with anxiety, whereas on the other hand, chronic pain is sometimes associated with depression. Chronic pain is an aggravating type of pain. It's a long-term pain. It's a never-ending pain. It's not as intense as acute pain. It's something that the examinee has experienced before, and by the time they get to you in the face-to-face evaluation, they will have developed many ways and means of learning how to deal with it. Now, using our terms of art, the chronic pains that we're going to see predominantly on the workers' compensation system are of the variety that we refer to as the minimal and the slight pains, meaning that these types of pain interfere less or interfere not at all with activity. In other words, this type of pain is not as severe, is not as continuous, and is not as disabling, and is less associated with evasive action. And this is more the type of pain that we're going to see in our examinees who present to the qualified medical evaluation months and sometimes even years after the initial injurious incident, which at the time was more associated with acute pain. But now that months and years have passed since the date of injury, the pain will have evolved into more of the chronic pain type of definition. Now, with acute pain, the reason the pain is so severe and oftentimes disabling and so demonstrative of evasive action has to do with a process known as peripheral sensitization. So with regards to peripheral sensitization, when tissue has been damaged, and let's for example, let's talk about a grade 2 sprain of the ankle. There's a grade 2 sprain of the calcaneofibular ligaments, and the examinee has swelling, has ecchymosis, and has acute pain from, say, an inversion injury to the ankle. Well, when tissue has been damaged, such as stretching and tearing of ligamentous tissue, such as stretching and tearing of joint capsular tissue, substances are released, and substances include substances such as bradykinin, prostaglandin, histamine, substance P. These so-called cytokines are released that lead to inflammation, and this causes peripheral sensitization of the nociceptors, which results in localized pain. So this is a local phenomenon. So with regards to the sprained ankle, I don't know if you've had a sprained ankle, but perhaps you can relate to this story. When a patient in your clinical practice presents to you with a sprained ankle, and there's swelling and ecchymosis and all these positive physical examination findings, and you go to palpate the ankle is hypersensitive. It's acutely sensitive. In fact, they may withdraw from your touch of the ankle, even light palpation of the ankle. And this is because the nociceptors at that location where the tissue has been damaged have become sensitized through the release of these local inflammatory substances. And this sensitization of these local nociceptive nerve endings lowers the membrane potential threshold for depolarization and the transmission of a pain impulse up into the central spinal cord system. But this peripheral sensitization occurs in the periphery. So this is a common characteristic of acute pain that you should not find in the chronic pain setting. Now, with chronic pain cases are going to be more associated with what's referred to as central sensitization. And the central sensitization has to do with an up-regulating of the pathways in the central part of the pathway, the spinal cord, and the ascending pathways up into the brain, and even in the descending modulatory pathways from the brain down to the spinal cord. It's in the central where the system becomes amplified and upregulated, leading to excess pain in a chronic pain setting. So with central sensitization, if the injury does not follow a normal healing pathway and becomes chronic, this chronic pain is transmitted by what we refer to as central sensitization. So this involves the spinal cord and the brain and is not associated with actual or potential tissue damage out in the periphery. So this is manifest as widespread as opposed to localized. So here's a key distinction and difference between acute pain from the periphery and chronic pain, which is mediated centrally, is that with acute pain, the pain is localized, versus with chronic pain, the pain is widespread. So it's widespread hypersensitivity to physical, mental, and emotional stressors. For example, touch, vibration, mechanical pressure, noise, bright light, temperature, and also emotional stressors such as fear, anger, guilt, suppression, etc. So again, in an acute pain setting, with an acute injury, we expect to see acute pain-specific findings, such as peripheral sensitization, whereas in chronic pain settings, we expect to find pain symptoms more associated with chronic central sensitization. And there needs to be consistency, and this is one of the things that you're going to be acutely attuned to, is consistency between the examinee's pain presentation and the history of the examinee's case. So here's a diagram that depicts peripheral sensitization. And let's go back to our example of the grade 2 inversion ankle sprain. So here we have the injury that results in damage to ligamentous tissue, capsular tissue, perhaps there's some muscle strain tissue. And so this damaged tissue, damaged cells, release their contents and release inflammatory exudates, which are picked up by nociceptive pain receptor endings. And these nociceptive pain receptor endings become increasingly and overly sensitized due to the presence of these inflammatory substances. So these nociceptive endings, which would result in normal pain messages traveling along the periphery to the sensory nerve and into the spinal cord, because of their oversensitization, this tiny stimulus in the periphery results in a barrage of pain messages that overwhelm the gatekeeper cells in the spinal cord and reduce the ability of gatekeeper cells to filter the pain messages, which then ascend up into the brain regions and the primary somatosensory cortex and also in the emotional areas of the brain, and that becomes interpreted by the patient as pain. Well, with peripheral sensitization, the sensitization is occurring out here in the periphery. So this is the type of a finding that we would expect to see in an acute pain setting, rather than in a chronic pain setting. And the end result of peripheral sensitization is that the amount of pain that the examinee feels is out of proportion to the extent of the injury, and that has to do with the increasing sensitization of the nociceptive endings. So let's compare that with central sensitization. Okay, so here we see with central sensitization begins first with peripheral sensitization. So after an injury, a nerve injury or other tissue type of injury, an increased input due to peripheral sensitization into the dorsal horn can then induce central sensitization. And these different sensitizations are sometimes referred to as primary and secondary hyperalgesia, with peripheral sensitization being referred to as primary hyperalgesia and central sensitization referred to as secondary hyperalgesia. So central sensitization is secondary to peripheral sensitization. So with central sensitization, we have this increased nociceptive afferent barrage into the spinal cord. And then due to this increased release of pain neurotransmitters, such as glutamate and substance P here at the level of the spinal cord, starts to induce changes at the spinal cord level. And the changes at the spinal cord level result in an increased pain amplification and increased perception of pain into the brain region and into the emotional regions of the brain. Now, what takes place here in central sensitization in the central aspect of the nervous system is complex and is perhaps beyond the scope of this discussion. But what's important to understand is that the changes are occurring centrally, whereas with peripheral sensitization, the changes are occurring out in the periphery. And both of these changes have the same end result, and that is an increased perception of pain in the mind of the examinee. So with central sensitization, we expect to find this in the chronic pain setting. And so this is something that you're going to encounter time and time again in your examinees who present to you months and years after the date of their actual injury. Now, related to but different to peripheral and central sensitization are concepts known as peripheralization and centralization of symptoms. So here we have an examinee with a localized lesion of the lumbar spine. As this lesion starts to worsen, the distribution of the pain symptoms starts to become more diffuse and more peripheralized. So in this case, with a bad lesion of a lumbar spine herniated disc, for example, the examinee will report pain radiating away from the site of the lesion, and how far that pain radiates down the leg gives you an indication as to the severity of that lesion. So as symptoms become increasingly peripheralized, it gives you an idea as to the severity and the troublesome nature of the lesion. So with peripheralization of symptoms, the area of pain enlarges or becomes more distal as the lesion worsens, whereas with centralization of symptoms, the area of pain becomes smaller or more localized as the lesion improves. So again, using our example of a herniated lumbar disc, as this herniated lumbar disc starts to improve, the pain starts to recede out of the leg and becomes more localized or centralized to the site of the original lesion. So improvement, clinical improvement, would seem to be moving in this direction, whereas clinical worsening would seem to be moving in this direction. And this is important to note, the distribution of pain and the pain patterns that are reported to you by your examinee.